Wendy Sansom. I'm from Boxall Hospital in Melbourne, which is part of Eastern Health. And I've been practicing stomal therapy since the mid-80s, 1984 actually, I did my course. I've been very aware of Convex products since they came out. I would say my usage of Convex products has increased over the years, and I think that's reflected in meeting the demands of the sort of patients that we see now. I'm very mindful of using Convexity when it's needed. There's a huge variety. It's certainly changed over the years. I mean, we've got the really soft, flexible, the mouldable, the variations in plateau size. We've got deep. I think the difficulty is there's no standardised definition of what a convexity, a soft convexity and what have you is. I think that would be really helpful if we had that. Certainly if you've got a retracted stoma, even a flush stoma, sometimes even a spouted stoma, but if it sort of retracts when you lie down, I think the use of convexity is totally driven by patient assessment, and I think you just have to, it's very, very individual. There's sometimes I use convexity when I wouldn't even think that convexity would be a suitable thing that I should be used. There are a few patients that I would be, or conditions that I would be very reluctant to use it, such as ulceration, certainly pyoderma, which is very, very painful, so I wouldn't want to add any extra pressure, which could be painful. Varices, peristomal varices, which may increase the potential to bleed. And again, you've got to include the patient with comfort and things like that. So I certainly think it's very variable, but driven by patient assessment. Possibly don't start out with convexity, but yes, I wouldn't say the majority of patients, but I would think that it's probably very even. Whereas maybe several years ago, 5 years ago, even more, it certainly would have been more flat. But there are instances now where I will go to convexity immediately, even in the immediate post-op stage. And I think, as you know, that where I work, we've been doing some evaluations or trialling a different sort of stoma in the umbilicus. I have noticed we've had that actually written up as our first trial, but we're now on our second trial. I use convexity as an instant go-to because I just know that that will work. Well, I think the main benefit is that we have it there as an option to start with, and we've got the varying degrees and the different types of convexity. There are some people that you might put that would be suitable candidates for a flat, but bearing in mind where they live, even if they're in a care facility, if they're miles away from access back to follow-up, you know that will get anybody out of trouble. So I think that there is certainly the advantage of having it there, that you know that it is a need, but in the back of your mind it's there that maybe I should use this because if this person gets into trouble, they're going to have a lot of difficulty getting back in for distance-wise and what have you. Yeah, I do think more is needed because there wasn't, well, you'll never get 100% compliance anyway or agreeance, and I think things change. And I think that we use more convexity now than we used to because we will operate on people that are a lot older, they're going to live a lot longer with stomas, but I think the main thing is the obesity. And certainly the technicalities of the surgery. We're doing a lot lower joins or anastomosis now than we used to, which means that the stoma may be under a lot more tension, and combine that with a much larger abdomen. Therefore, yeah. So I think the boundaries change all the time. So it is worth revising, trying to get a consensus fairly frequently, every 3 to 5 years or whatever, as the goalposts move.